So thank you all for participating, those who are listening in and those who've agreed to participate. This is going to be an incredibly fast-moving session, which is appropriate given the fast movement that Dr. Kim alluded to in the development of telemedicine. So without further ado, I'd like to introduce our sort of keynote speaker to kick things off, Dr. Patricia Grenton. Patricia is a board-certified pediatrician and a member of the American Academy of Pediatrics. She's got over 25 years of clinical and leadership experience as a senior physician and virtual health medical director. She completed a residency at Carolinas Medical Center in Charlotte and holds a bachelor's degree in chemical engineering, completed medical school at SUNY Health Center in Syracuse. For our purposes, I think there are two things particularly relevant. One is that she's Atrium Health's virtual health innovation. She's part of Atrium's Health Virtual Innovations Program. And as medical director of the community-based virtual care, she can directly address how Atrium, with several million individual patients in the North and South Carolina market, and up to 16 million nationwide, has come to understand the options for virtual care, particularly in reaching those patients who might not have as much access to conventional care. She added one interesting fact that I think may be interesting to our Korean colleagues, which is that in 1992, she competed in the International Ekiden Race, a marathon relay race held in Seoul, North Korea. And while she says she runs a little bit slower, I don't think you'll find that as you look into what she has to share with us about telemedicine. So we're honored to have her begin a session that's going to cut across multiple continents and multiple different activities. Patricia.
Thank you, George, for such a kind welcome and introduction. Would you like me to share my screen? And I am ready for that if needed.
Yeah, if you can do that, please do.
I sure will, thanks. Can everyone see it okay?
Yeah, it looks great, thank you.
Awesome, wonderful. So, gosh, this is like great, you guys. I find it always so incredibly exciting to gather with such thought leaders, international thought leaders, and how we can make a difference in the world and impact our communities, specifically our communities who do have struggles to access care, and how we can leverage technologies to make that a happier and healthier community. Over the next 15 minutes, what I'll do is I'll give a real high overview of the team I'm part of, and then drill down into that community-based virtual clinic that George alluded to. And so let's see here. All right, so as George alluded to, I am part of a great organization, but it is very robust and widespread. We cover the Southeast region of the United States. We have about 10 million encounters annually. And with that in mind, you can imagine we have a whole host of virtual technologies to ensure that we serve our patients within their rhythm of life. And we cover the gamut on quite an extreme. We go from tele-ICU, so we have our critical care intensive doctors managing patients in a hub and spoke model where they sit in one location, and then we have maybe 5 ICUs, and maybe 10 patients in each ICU, and that one critical care physician is able to manage that. And then on the level of acuity, we span all the way down to the other side where we take care of patients using just the good old video and audio connectivity. And we call that our on-demand platform. And that is available 24 hours a day, 7 days a week, 365 days a year. And we have about 40 to 50,000 visits annually in that space as well. But for the next 10 minutes, I'd like to hone in and really focus on community-based virtual clinics. And why behind that, we'll talk about who it impacts, how we do it, and the outcomes. A lot of fancy words in here, but basically what we do is we leverage partnerships within our community. So the healthcare system and community partnerships, we come together to improve access to care. And by doing that, we mitigate disease progression, we reduce health disparities that we see so often in access-limited communities. And we really just strive to serve our patients within their rhythm of life. Sometimes it's always good to reflect on saying, you know, why is it that we do what we do, right? And we know this work is oh so important. And sometimes the best way to help tell that story is actually through a patient's experience and a patient's eyes. So, so here's my patient story, and you'll see this come full circle at the end of the 10 minutes. So this is Natalie. She loves the Eastern Atlantic beaches of the United States. Her favorite ice cream is Cheesecake Rainbow. Her favorite superhero, as you may be able to tell by the little pink pom-pom there, is Wonder Woman. That's her gold bracelet, analogous. And interesting enough, Natalie's favorite animal is the monarch butterfly. And I found that fascinating when Natalie told that to me when I was taking care of her one day. And I was like, the butterfly, really? Tell me more. And she's like, well, silly you, Dr. Brinton, the butterfly's wings are very similar to my legs. They're beautiful and okay to look at, but if you touch, you must be very gentle, Dr. Brinton. And so this is Natalie. Natalie is a beautiful young lady with congenital epidermolysis bullosa. And with this condition, her skin is very frail. Just the minimum amount of trauma, any fabric rubbing over that will cause significant skin breakdown and puts her at significant risk for secondary infection. And you can only imagine the sequelae that happens from there: emergency room visits, hospitalizations, etc. So we're going to go full circle on Natalie and tell you how community-based virtual clinic has changed her life and her family's life. So again, it's hard to talk about what community-based virtual clinic is in an hour lecture, let alone 10 minutes. So I'm going to give you a real high level of the secret sauce is partnerships. It's all about partnerships, whether it's external partnerships or internal partnerships. So externally, what we do in a community-based virtual care clinic is we do not build a bricks and mortar. We partner with existing structures that are in place, whether that's a faith-based organization in the community, whether that's a school in the community, whether that's like a fitness center in the community, and we partner with them. They usually pull us in, the lean method, and say, we've heard about your work, will you please come to us? Our community struggles to access care, and therefore disease has progressed, and there's just significant healthcare disparities. So community-based virtual clinic is all about partnerships. Our clinic is established within a practice that is not, or a bricks and mortar center that is not owned by us. We don't need a lot of space to do this type of telehealth care delivery, and you'll see it involves very little. And so when we go into those spaces is always limited. People joke that we partner with, and we say, well, do you have an extra coat closet or like a spare janitor room? Because we can always convert that. So we probably need about a 4x6 room, and that's what we can create as a community-based virtual clinic site. So as I spoke, it's all about partnerships, right? So we take our external partners and we get trust and buy-in in the community. And then of course we layer in our internal partners. Atrium Health is a vertically integrated non-for-profit healthcare system, and therefore we almost can do wraparound service. So we can offer mental health services, we can offer medical care, whether that's pediatric care, cardiology care, primary care. And so we set up these structures, these community-based virtual clinics that, to this group, I'll just let you know, are often repurposed closets. And And with a little bit of clinical teammates on site, we can layer in a multidisciplinary clinic without the specialists having to come to that location. Because again, we're talking about limited access places. So therefore it'd be very unsustainable and not feasible for those folks to travel to those places, those specialists. This is just a pictorial, again, high level of what community-based virtual care can do. We do chronic care management. We do a lot of mental health management. We have an epidemic in the United States and certainly a need for mental health. And we do a lot of acute care needs, right? And so it's all about meeting the patient in their rhythm of life and getting them back to their community, their classroom, their employee, and their employment. So how does it work? And here's where I'll pause because it's a lot to digest. And I'm just going to try to walk through it slowly, and feel free to ask questions after. We have a multitude of community-based virtual clinics, maybe in one community. For example, the community I live in now, we have about 30. So they're at all the schools. Every school has a community-based virtual clinic. Our local fitness centers, several faith-based centers have those. So maybe I'm at the school and I say, oh, I have an earache. It's very well socialized that this service is available. I call a centralized number. They answer the phone and they say, oh, sure, we'll deploy a teammate out to you to help facilitate this examination. So our clinical teammate travels to our community-based virtual site with a little digital technologies, which include an iPad and a case, which has our digital technologies within it. They meet the patient out there. And again, this is a clinical staff member. It is not an RN, not quite that high level of education or certification is necessary. So it's easy to find needed resources. The patient and the clinical staff member complete an examination in our private, secure medical space. They do this by using innovative technologies and connecting with a provider that is remotely located. And so the technologies are pretty cool. We've come a long way. Before it used to be this big old thing with a wire and attached to a laptop that was kind of heavy. But now here's my stethoscope and we lay it on the patient's heart, our technician does, and our physicians remotely located hear the patient's heart, lungs. We usually do a comprehensive physical exam. We have a lot of ear infections, and so we put it in their little ear, and it's displayed for our physicians that are remotely located. And instead of in my office, I have about a 2-centimeter aperture window to look through, where when I do this care delivery through community-based virtual, I have this incredible 24 by 20 centimeter screen to examine their eardrum. We can look at their throats. And if by chance that patient was deemed to need some lab evaluation, whether it's a throat specimen collection for strep throat, whether it's COVID sample collection, if the patient's old enough to give a urine sample and self-collect, we collect urine samples. So we can complete the whole total physical exam in that community-based virtual site with providers located quite remotely. The patient is evaluated, a diagnosis is come to, a treatment plan is put in place. We send our prescriptions in electronically to the pharmacy of choice, and the patient goes on their way, and our clinical teammate who was deployed to that site has usually by then received another call to deploy to the next site. And so usually there's about a 15-minute wait for that patient to meet the telepresenter. The visit takes about 15 minutes, and then in 30 minutes, that person is back doing what they normally do. And certainly in the United States, there's not many things you can get done in 30 minutes, let alone a medical evaluation. So that was a lot to say, and thank you for being so patient as I explained that probably a bit quickly. So measures of impact, right? Why do we do what we do? And we have to make a model that's sustainable. So this type of community-based virtual care came to my community initially because in the United States, depending on what academic study you're studying, 70 to 90% of ED utilization is actually for primary care needs. So we classify that as inappropriate ED utilization. why do people use the emergency room? Not because they like to sit and wait hours for primary care needs. It's transportation, it's work schedules, just for a multitude of reasons. It's the emergency room seems to be the easier way to go. So what we wanted to do is make sure that we meet our people in their rhythm of life and help mitigate that ED utilization for inappropriate uses. And so what we found is a substantial reduction in emergency room utilization for patients who utilize community-based virtual. We studied in pre and post, involvement in our community-based program and studied in post. And it's one of the most impactful modifications we've seen in emergency room utilization and the reduction of it. Our employers and our teachers and our schoolmates taught us about the return to the community. You know, I see so many things in my office and I'm like, oh, I hate that you had to miss school or work or anything like that, that we knew really aren't contagious. And so pre-COVID, we had about a 90% of our patients returning back to the community. So 90% of the things we saw, we deemed non-contagious and just go back to what you're doing, whether it's learning, employment, or just enjoying life. Since COVID, that number has dropped just a little bit because now if somebody has a runny nose, we often exclude them until we know that COVID test result. So those are our KPIs for community-based virtual. And then coming full circle. So Natalie, so where is she now? Natalie, pre-community-based virtual was averaging more than 6 emergency room visits per year. She's had none in the last 5 years because now she has access to community-based virtual. Natalie was considered a chronic absenteeism student, and that's defined as 10% of the school days are missed. And she now, mom reported she missed 1 last year, and that was due to a virus with a fever. Natalie had 3 hospitalizations in the last 4 years prior to community-based virtual. And since the inception of community-based virtual, Natalie has had no hospitalizations for secondary skin infections associated with their impetigo or their epidermolysis bullosa. So, so all that to say, thank you for this opportunity. We definitely can help our limited access patients by leveraging our innovative telehealth technologies. And through groups such as this, we share ideas and we just catapult to new areas and new opportunities. So with that, thank you so much.
Thank you, Dr. Brinton, for an amazing presentation and for sharing with us Natalie's story. What we're going to try and do, given the rapid fire presentations, is take at most 1 or 2 questions now and save the others for the panel. So is there a critical question that someone would like to ask Dr. Brinton now?
I've a quick question or comment. Now, the Korean government has allowed telemedicine temporarily, starting from February 2020, in the middle of the pandemic situation. And Dr. Eun Lee has been known as someone who practices telemedicine only clinic. Dr. Lee has mentioned the shortcomings or limitations of telemedicine, and it seems that, as George noted, some of these issues are already addressed with this community-based or local clinic-based approach of Atrium Health. So I would appreciate if Dr. Brinton could, say something about this, and then Dr. Eun Lee could follow up on that. If Dr. Eun Lee doesn't feel comfortable with her English, I can translate definitely. So I would ask Dr. Brinton to give some comment on this.
Yes, so the points that Dr. Lee brings up are very pervasive, right? And so certain things we can do just through video and audio connection, some rashes with the right lighting, and certainly, a cold without an ear pain. And so we found that with our video audio connection, it was very good. And about 70% of the time with primary care needs, a history and a minimal generalized exam is sufficient. But especially in a pediatric population or in the elderly population, auscultation of the heart, the lungs, vitals, because we get vitals as well, was so critical to almost like close the loop. So it's almost like care to you in the amount of intervention that you need. So if you just need two-way FaceTime, you probably could do it from home. But if you happen to have an earache, just travel a quarter mile down the street to your local school or faith-based organization, and you can have a more comprehensive physical exam. Sometimes when I'm presenting, I joke with my audience and say about the only thing I can't do is smell you, which as a pediatrician, that's not a bad thing sometimes. Did that help?
Yeah, thank you.